Hey everyone, Army veteran Mike McNamara here from the SIT Rep. Today, we have a real treat. We're joined by Dr. Karen Francione, who's the Chief of Trauma and Recovery Services for the Post-Deployment and Readjustment Clinic at the Providence VA Medical Center. Does that fit on a business card?
It's a little long.
It's a little long. Today, we're going to talk about PTSD and most importantly, your guys' efforts in defeating the stigma of getting treatment for PTSD. So I guess probably, you and I were talking off camera a little bit, and probably the best place to start is, what is PTSD? When people talk about that, what is it exactly?
Sure. So when we think about post-traumatic stress, so just to kind of keep in mind is following a trauma, it's normal for anyone to have upsetting thoughts or memories, nightmares, trouble with sleep, kind of feeling startled or on edge. And for some, those symptoms will go away as we sort of take some distance from the trauma. But for others, those symptoms will remain. And for those folks, we might end up going on and diagnosing them with a trauma-related disorder. And I use kind of the broad word of sort of trauma-related disorder because when we have exposure to trauma, people are going to have different symptoms that they're going to experience. And so those symptoms might not map onto a diagnosis of post-traumatic stress disorder, but that by no means means that their trauma is not as significant. It just means that their symptoms look different. So when we think about the diagnostic picture of PTSD, that obviously we're talking about exposure to a trauma.
Okay.
And that trauma for our veterans can be military related, but I think it's also important to remember is that it can be what people might say like civilian or non-military related. So when we think of, say, military trauma, we're thinking about things such as combat, exposure to life-threatening events, being seriously injured, seeing someone else seriously injured or possibly dead, handling human remains, also serious accidents. Civilian related, I think for some of our veterans, we are talking about violence in adulthood, but also through childhood, natural disasters, terrorism. So following a trauma, symptoms will sort of fall into 4 clusters. And those clusters are re-experiencing or reliving the trauma, avoidance, arousal, and changes in sort of mood or affect. And so, those symptoms will last for folks greater than 1 month for a diagnosis and be impacting their functioning. So maybe it's at home or work, or it's causing them significant distress.
Okay. I think you hit on a really interesting point in that many people out there, both veterans and non-veterans, think that PTSD is combat related, so men and women who experienced, different degrees of combat have PTSD. And that if I never deployed or never went overseas or were never in a combat situation, then I can't have PTSD. And that's just not the case.
Right. And it's definitely something that we hear when folks are coming into treatment for us is sort of saying, they might say to me, well, I served, but I never deployed. So I can't possibly have PTSD. Right. And that's really not the case at all. Just thinking about the jobs that people sort of engage in prior to or after the military.
I'll be honest, in my own situation, I saw more individuals lose their life in training accidents in the States than I did actually combat fatalities when I was deployed. So yeah, I would definitely say in my own personal case, I was exposed to traumatic situations much more so back home in training scenarios than I ever was in a combat situation.
Right,
so I think that's a good distinction to have, that just because you didn't go overseas or you weren't a door kicker, so to speak, in downtown Baghdad, doesn't mean you don't have issues.
Exactly.
Okay. I think another good thing to transition to then is, why is there stigma associated with PTSD? I mean, correct me if I'm wrong. I mean, man, woman, makes no difference.
Right.
Age is not gender, nationality.
Right.
None of those factor in. It's just it's a human condition.
Right.
But so why is there such a stigma associated with it then?
So I think truthfully, I think there's a lot of misunderstanding and misinformation out there about post-traumatic stress. And I think kind of our role is we need to talk about it. And so having conversations like we have today and hopefully kind of continue on to sort of talk about what it actually is and sort of the treatments that we have. And so, because we know that stigma keeps people from getting needed treatment. And so if you think about post-traumatic stress, we're thinking about some folks, they might have higher rates of depression and substance use and suicide. And we want to have the opportunity to engage with folks. And so I know a lot of VAs and us included are trying to create relationships we have a large National Guard units here. And so, making some inroads with them or bringing folks in when they do their PDHRA, having them come to the VA, meet with primary care, do what they need to do from a medical standpoint, but all of them also have to meet with someone from mental health. And, my feeling is, I got the chance to meet them. They can kind of size me up and get to know who I am a little bit. And I can just give them a brief, story about, the treatment we have. And the hope is maybe not at that point they want to come in for treatment, but maybe a month later, 2 months later, 3 months later.
Exactly. I know, once again, from a personal standpoint, when I came home from deployment and came to this facility, as a matter of fact, for my redeployment, and it was a wonderful experience in that it was basically one-stop shopping.
Right.
I was able to file a claim here, but more importantly, from our discussion, I was able to have a discussion with somebody, and it was one-on-one in a room. There was nobody else around. It wasn't a group setting or anything, and just in that conversation with that individual, kind of helped me understand that maybe I might want to pursue a few things further. Right. So I think that's an important piece.
Yeah, and just to kind of start, because I think the other really important part is that the symptoms of post-traumatic stress might not appear directly following the trauma. So the symptoms might not show up for a month, 3 months, 6 months, a year, or longer. And so, it's important for us to continue to have that dialogue. And, when someone goes to their primary care doctor, being honest and letting them know what's going on, and then allowing one of us to kind of step in and help.
I think you mentioned primary care in the sense, and I think that's the other issue. People feel like I'm healthy, so I don't have PTSD.
Right.
I'm a healthy person, so how could I have PTSD? But really, PTSD is not really associated with regular health or bodily health, I guess.
Right. And so, and I think you brought up a good point, is that PTSD does not see race or age or profession or rank in service. And I think that's actually really important for potentially higher listed, up-listed folks in terms of getting the treatment that they need. And, I think the other piece is that there's this biological, we're learning so much about the brain and PTSD, and sort of recognizing, we all probably remember in biology class, like the fight or flight, fight, flight, or freeze response. And so that alarm system. And so what we're learning in PTSD and looking at brains is that alarm system kind of stays on. And it's not only alerting us to kind of true danger that's in front of us, but it's also potentially alerting us to danger sort of based on our thoughts and our feelings that we're having. And so, we're learning, and that's driving some of our education in terms of treatment. And so I think for folks to kind of recognize that it's our body's reaction, and we want it to have a reaction to trauma.
Right. You've brought up some interesting points, and I think one I'd like to explore a little bit is, in your opinion, then, why don't veterans want to come in? Or, obviously we've talked about the stigma related issues a little bit, but I think in your opinion, your experience, what are the biggest factors that veterans have expressed or that you've understood that they just don't want to seek treatment?
Well, I think if we think about, our veterans have been trained to sort of overcome challenges and, overcome pain. And here's another example of I can just power through it. I think I've heard more than multiple times is this will just go away on its own. I take the uniform off, all will sort of be okay. Or, I'm worried about, if I share this, how will it impact my career? If I share something, will they then, will I have to go to the hospital? And that's not sort of the case. I think some folks are, don't really want to talk about it, or feel like, how could I possibly understand what someone would be kind of going through? And I think, for all of us to recognize those feelings that folks might be bringing in the door. And so how do we as providers try to break through some of those?
You just brought up a great point that I wanted to talk about, and you said, especially here in New England, we have a big reserve component population. So talk about what your responsibilities are as far as reporting issue. A lot of veterans will say they don't want to come in because I'm afraid information will get out. I can't get promoted, or they'll never let me carry a weapon again, so I won't be able to be in the military. So how does that all play? I mean, are those fears real, or is that, obviously we all understand HIPAA and stuff. So how does it all play together?
Right. So, I mean, that's a great question. And so we take confidentiality very, very serious. And so at the very beginning of our session with someone, we'll talk about our limits to confidentiality and sort of the standard limits of if you tell me you're going to hurt yourself or someone else, there's a immediate threat, or there's any risk of injury to a child, abuse to a child or an elder. Obviously, a mandated reporter would need to share that information. Outside of that, I do not share information with family members or employers unless there's a signed release. The veteran is asking me to have that communication. And there are times where that will come up. But that's a conversation we're going to have together. We're going to talk about what that information that is wanting to be shared, what it's going to look like, what's the time point at which we're going to give this information and it's going to end. When it comes to the military, and I know we've kind of talked about before, is that there is a sharing agreement with the Department of Defense. And that's really was designed to allow for communication. So when someone transitions out of the military, that paperwork is following with them to the VA. And so it does help with continuity of care. Say for us, if folks are seen at Newport Naval, I can have access to those records. So I will talk to folks that sharing agreement is in place and then allow the veteran to sort of make their decision. Sometimes, we are extremely fortunate where we are with the quality of care that our veterans get at our vet centers, both in Warwick and Fairhaven and Hyannis. And so sometimes if someone is concerned, I will sort of make a referral there because I want them to get the best treatment possible.
Well, I think what's important to make sure that our viewers understand is that if a veteran is not showing or an immediate threat to himself, herself, or their family or somebody, and they really don't want their information shared, then if I call up as their commanding officer and say, hey, I think my sergeant is getting seen at the VA. Can you tell me what's going on? That's not going to happen.
Nope. Nope. Even if, I get calls when folks do background checks. And so from field investigators, and I'm still calling the veteran first and we're having a conversation, I'm seeing the signed release that's being faxed over to me before those conversations occur.
Okay. I think that's really important. Yeah. I know that's keeping people who may need help from seeking help because they want to continue their military career and they're afraid that by getting help, it could end it. So I think it's important, like you said, that, unless they're demonstrating some type of immediate threat to themselves or others, then, it's strictest of confidentiality, their conversations with you or the other providers. And that's not going to be shared with their command or anybody else. And you brought up an interesting point, and that was family members. So what can family members do? In the sense of most times, I know when we interact in public, doing outreach events or what have you, we end up talking to family members a lot of the time. The veteran, he or she may not be eager to interact with us, but it's the family member who approaches us and says, can you help him? Can you help her? So what can family members do? What should they be looking for? And then what are their options as far as reaching out to the VA to say, I think my loved one needs help?
Right. So, I mean, that's actually some really great. So, even when a veteran is in care, sometimes I will receive a message from a family member. Obviously, I can't confirm or deny sort of their involvement in treatment, but always a welcome to any information that someone wants to kind of share me. And as chief of the service, kind of can sometimes get those phone calls and they don't even pertain to my veterans. I think, we try, it's important that a veteran know that their treatment at the VA is voluntary. So, we might get a phone call from a family member, but it's really important. And sometimes I'll say to the family member, maybe have the veteran, while you guys are together, call, and if you'd like to come to the first visit, to get some psychoeducation, I would encourage that. And we encourage that ongoing with veterans. If I have a partner who might be be struggling with how to best help the veteran during some difficult times, I might say, you want to come in for a session and we'll kind of talk about what post-traumatic stress is and how it's impacting things. And the Vet Center, I'd also say, is a great resource in terms of family members getting some
Right. They can get
support.
family counseling at the, that's a great point.
Yeah. And I think kind of going to the outreach, events, or, even accompany a veteran to their primary care appointment, or if that's something that's possible, to kind of let the provider know what's going on.
Okay, good. So I'm a veteran. I make the decision. I think I need to talk to somebody.
Yep.
So what can I expect? I make the phone call. I get referred.
Yep.
I get an appointment. What can I expect when I walk in the door?
Right. So the first appointment, it's going to look a little bit different than appointments sort of down the line are going to look like. So that a first appointment might take anywhere from 60 to 90 minutes, kind of based on what's going on. And, the way I often kind of start my initial appointments is just really asking, the veteran, what kind of brought them in, what's going on. I want to know kind of what are the symptoms that they're having. And I want to know how it's kind of taking things from their life, impacting their life, maybe in a negative way. But then I will ask some standard questions. So I will ask about military service, and it can be very general. I might just ask about the units. What deployments did you have? What was your MOS? What did you do? During that time. I will ask about substance use. I'll ask about some questions about family or psychosocial functioning, their support, if they've been in treatment in the past. And so, we'll be gathering, as much information as I can about symptoms. So obviously I'm going to be asking about depression and anxiety. And depending on how long those sessions sort of take, I might, at the end of that session, have a conversation about treatment, in terms of, I will talk to them about their diagnosis and give some feedback about what I'm kind of seeing going on, and enter into a conversation about that. And we'll start the conversation of, the VA, it's very veteran centered, and we want to have a shared decision around treatment. And so we'll talk about what treatment options we have, and sort of go over the pros and cons and get a sense as to what might be the best plan for the veteran.
Now talk about the difference, because I know there is one. So you're doing what you do, but if you feel that a veteran may benefit from medication, you then have to refer to a psychiatrist or something. So talk about how that process and how you guys work together. And
yeah, no, that's great. So sometimes if someone comes in for an initial appointment and we kind of decide at that point, it would probably be best to get them started on a medication sooner than later. We're really fortunate to have what we call urgent care, which is kind of, I always say to the guys, it's kind of like our version of sort of the emergency room. So it's always staffed with a social worker and a nurse practitioner who is able to prescribe medication. And so sometimes if I know there is a wait to get in with a psychiatrist, I'll sort of say, let's walk up there. Let's kind of go. And sometimes I'll go into the appointment with them if they have some anxiety about that initial appointment, or, respect boundaries in terms of that. If they sort of feel like, I think I can wait. We work all of our psychiatrists are within general mental health. And so we'll reach out, we'll put a referral over to them. And then usually the provider will kind of cycle back to the psychiatrist or the nurse practitioner who's working with them, and to provide them some information. And then they'll also do their assessment too. And we coordinate beauty of an electronic medical record is that you can get a sense as to what's going on with the veteran. So they can read what's going on in my sessions. I can know what's going on with them. And if I'm concerned about something, we can alert each other to that.
So I think that's a critical piece, is it's a team approach.
Yes.
And if the veteran's more comfortable talking to you per se, then maybe he or she just needs to talk to the psychiatrist just about medication issues.
Right.
And then actually talk about PTSD issues, say with just you, or vice versa.
Exactly.
Okay.
Yeah. And that we work, and we recognize that, because I think, fits are really important. And so if you're going to feel more comfortable kind of talking about that, I might share with the psychiatrist a little bit more about what the symptoms are sort of going on. And I think we also take a team approach when it even comes to, their primary care doctor. So there's many times where I'm reaching out to a primary care doctor and sharing, if a veteran is having a concern, and, sharing with them, and they will do the same to me. And so I think there's a lot of value in terms of the way in which we look at like whole health. We're looking at the physical and the emotional pieces of wellness and working together.
So that's a great point too. So talk about the treatments. Like I think a lot of veterans feel like they're going to make me relive every single episode I ever went through,
Right.
or they're going to give me shock treatments, or I mean, there's so much stuff out there.
Right.
And if you turn the television on, obviously, One Flew Over the Cuckoo's Nest or
Right.
something like that, you see all kinds of stuff. So
Right.
I think it's important for veterans to understand there are different forms of treatment, and so talk about,
Yeah.
making people relive traumatic events, or what else may be happening.
Right. So I think there's like two pieces to that. And one is sort of the reliving or sort of re-experiencing. And so, I will definitely talk with veterans about, kind of sharing if they feel comfortable. Like it is very veteran sort of driven, and so I'm going to follow their lead. And if they might say to me, I can't go there, like I can't talk about that right now. And I'm going to respect that boundary. And there might be times when I also say, oops, I think we got to like pump the brakes a little bit. And that all of our providers are very skilled in being able to help someone kind of be in the moment and slow down if they're feeling kind of really distressed. And even some of our trauma treatments we do, you don't have to go through, you don't have to do a trauma account for all of them. But I think that's definitely would be a barrier. If I thought, boy, you're going to make me relive every aspect of my trauma, I might not want to come into care either. So when you think about our treatments, we kind of break them down, or how I kind of broke them down in my head is that, we have individual, we have group. Many programs have intensive outpatient programs, and we have residential programs. And for someone to keep in mind is that your VA might not have all of those. Like, for instance, we don't have a residential program, but we're super fortunate to have great relationships with folks at Northampton who have, a PTSD program that's quite fantastic. And so when we think about treatments for PTSD, we can look at them as we have trauma-focused, evidence-based treatments. And evidence-based means these treatments have been well researched, and they've shown to result in a a reduction in symptoms and improved overall functioning. And so the names that people maybe have heard of are things like cognitive processing therapy, or CPT, PE, or prolonged exposure, and EMDR, which is movement desensitization, and it's a mouthful, and reprocessing therapy. And so those are very trauma focused. So in all of them, the plan is kind of processing trauma and sort of talking about it in sort of their own sort of unique ways. And if interested, we can talk a little bit more about that. And usually they're one-on-one. So provider and veteran sitting together. They're anywhere from 60 to 90 minutes. And we really look at trauma treatment as being dosed. So it would be maybe anywhere from maybe 10 to maybe 20 sessions that you would have that would be very focused on trauma. If someone feels like they come into care and trauma-focused treatment is not really where they want to be, and they don't feel like that's comfortable, I might start thinking about what symptoms might I be able to address. So I might focus on insomnia and focus on sleep, and thinking, well, if I can help them with their sleep, and maybe we can make some movement towards trauma, or focus on anger or interpersonal difficulties. And so again, we're sitting in that first session together, kind of going over like the pros and cons of different interventions that we offer. And sometimes I'll make them, I will ask them to look at things online and look at some videos that have been produced on different treatments. Group is a little different. I
was going to ask you about group. Because you brought that up, and some veterans may be more comfortable talking to other veterans. So what is group?
So you're going to be meeting with probably a therapist and a co-therapist and a number of veterans. And so our group sizes are going to vary. So they could be as small as 6 folks, and it could be a little bit larger, might be 10. And I think there's great value to group, because the veteran not only gets hopefully to learn from the provider, but really they get the chance to learn from each other and recognize what they're going through, like the guy next to them is going through too. And so it provides some normalization. And our groups can vary from, I do a group on wellness and, health, but we also do things on sleep, anxiety, just emotion regulation. So we offer a great breadth of groups. They tend to also be closed groups. So all the guys start together and the group at the same time together. And then our sort of the last piece is some programs, and including us, do an intensive outpatient program, which for folks that are potentially struggling in kind of individual therapy and we feel like they need a higher level of care, we might recommend, in the intensive outpatient program will look like 9 to 2, 5 days a week for 3 weeks, and they'll get a very concentrated dose of treatment. Well, they'll learn some education about PTSD, but they'll be able to learn and practice some skills related to PTSD.
And you've brought up some awesome points. So, and I know this is kind of a silly question in a sense, but how long does this last? Could somebody have treatment for life? Could somebody have treatment for intensive 3 weeks, or what's the...
So everyone's treatment plan is going to look different, and I feel like we are trying to move from a supportive model to really giving people so our treatment is goal focused and sort of goal driven. And so everyone's treatment path might vary, but our hope is that it can be episodic. You learn a good set of skills and that you're showing some improvement in quality of life, and you're able to take those skills and run with them. And then if you need to come back, you kind of come back, and we sort of retool any skills that you might need. But everyone's path is going to look a little bit different. That's a great question.
Okay, because I think that's also, once I say, am I crazy for life? And once again, we get to the whole stigma piece of this.
Right. And as a provider, I don't feel that way. And because I really feel that, my job is to help improve your quality of life. We know that post-traumatic symptoms are going to be there. It's, as we sort of talked about at the very beginning, is that there's changes going on in the brain. And we know things like increase in stress might bring some of those symptoms, or for some of our folks, COVID and being isolated and not being able to do the different things that they were doing before can definitely impact symptoms.
You talked about some relationships, and you talked about, being able to go to the facility at the facility care out in Western Massachusetts. What about care in the community opportunities? I don't want to have to drive all the way out to Northampton, Massachusetts. Can I go downtown? So it depends on the type of treatment that you're looking for. So, I feel we have, prior to COVID-19, we were starting to do more virtual care and using VA Video Connect, which is kind of our version of, it's probably not the greatest description, but like our version of like FaceTime. So where I can see you on a screen, you get a email message, an email link to you, you click it on, you wait in the secure portal. Hopefully I'm already there, or I'm kind of going to be there in a few minutes. And so we're able to deliver care in that format. So be it with COVID or outside COVID, that's always an option for folks, especially, I think of our folks even who live on the Cape. And so coming to Providence is definitely not an easy process. We also do telephone therapy and telephone groups, also VBC groups. So through COVID, we've really learned how to really perfect that model of care and be able to meet folks wherever they are. There are some times where we might have to make some referrals to the community. For instance, Women and Infants Hospital is somewhere we might refer our women to for various services. And so we do use our community resources when possible. Okay. So I guess the bottom line to all that is the veteran, he or she has a lot of options as far as their comfort zone and which direction they can take based upon, your recommendation, their family recommendation. So how does a veteran get involved? I'm assuming a veteran has to be enrolled in VA healthcare for all this to start. Right. So yes, with one exception. So for the most part, veterans do need to be enrolled in care to get mental health care here. And so they can go through the enrollment process. The VAs have an enrollment office on campus, so they can call enrollment. They can show up at enrollment. I encourage people to have their DD-214 form with them. But they can also access enrollment, the 1010 Easy form online. So through va.gov. There's also a phone number. They can mail it in. So, at outreach events is another way people can start that process going. So there's lots of ways you can get into the system. The only time when I sort of mentioned an exception is for military sexual trauma or MST. And so for those folks, there is a possibility with limitations that they might be able to get mental health treatment even if they would not be eligible for care. And so every VA has a MST coordinator, and I can speak to ours as she's absolutely fantastic and can really talk with the veteran and help them sort of through that process and ensuring that they get the care that they need. And 2 points. Sure. I think what's important to know about that too is, and another stigma is, a lot of people associate military sexual trauma with female veterans, and that's not always the case.
It's not the case at all. And so we are seeing it in male and female veterans that suffer from MST. And we also see the perpetrator as being male and female. So I think that's really important to kind of keep in mind.
Now, I think I heard too that for mental health, even if I had a dishonorable discharge and I'm not obviously eligible for a lot of VA benefits, I can still seek mental health benefits. Is that true?
Yeah. So there are some exceptions to those rules. And so I would encourage someone to follow up and to talk to someone in eligibility in terms of what we'd be able to do, especially in times of sort of crisis. We want to be able to meet someone regardless of what's going on.
Another fear we hear from veterans a lot of times is that if I get treatment for PTSD, I mean, we talked about the HIPAA rules and that, but you know, they'll lose their Second Amendment rights, so to speak. Like I won't be able to have a firearm, or the police will come take my firearm. So, you know, what's behind that, or what's the real truth behind that?
Yeah. So what I'll often, I will ask about guns, and I know people will have mixed feelings, and I ask everyone about this question. And really what I'm ensuring is sort of the safety of your weapons. I would like to know kind of, where do you store them? Where do you keep them? And I'm not going into your house. I'm not the gun police. I'm not, going in that way. But if there was a reason, if I thought you were at risk of harming yourself, we're going to have that conversation about guns. But that's really when I feel like, in the context of my discussions, is where those things would come up. And, again, I'm not speaking to any authorities unless there's a reason that someone is sort of knocking on my door asking questions about your weapons.
Well, Dr. Francione, thank you so much for being here today. We really appreciate you taking your time to discuss this unique situation that a lot of people, unfortunately, deal with on a day-to-day basis.
Well, thank you.
And for our viewers out there, for more information on this topic and other of your benefits, please search #TheSitRep on YouTube.